Assalamu alaikum. The communication day. Mrs. Kathleen Hayden, 45 years, poorly controlled type 2 diabetes on despite maximum therapy with oral hypoglycemic agent. Uh, Although she's compliant with the diet, the glucose is still high, 10 to 15 millimole. She tried but couldn't tolerate metformin due to the gastrointestinal side effects and is presently on glycoside and sitagliptin. The diabetic nurse has informed you that Mrs. Hayden has been having more osmotic symptoms during the last 6 months, worsen and worse, and wonders if it is time to change her to insulin. Her last hemoglobin A1C then taken 6 weeks ago was 13.4. Mrs. Hayden is not keen to have insulin. Her body mass index is 34. She has normal renal and liver function. It asks to discuss here present glycemic control, recommend insulin as a means of improving hair diabetic control and certain hair option. Okay, let's start, Dr. Roda. Are you ready?
Super.
Dr. Roda? Okay, Dr. Roda excused for family issue for 5 minutes. I will stop recording, then we'll resume when she's back. Okay, we can start now. You ready?
Yes, ready.
Here we go. Hello there, I'm Dr. Mukhtar, the doctor in the clinic today. You must be Mrs. Kathleen Hayden.
Correct.
You are 45 years.
Exactly.
Yeah, how can I call you today?
Call me just Catherine.
Okay. How do you feel now, Mrs. Kathleen?
I'm all right, doctor. Thank you for asking that. Yes, recently for the last couple of months, I have a diabetes, but actually, I'm drinking a lot of water. This reminding me of the early days that I got diabetes 4 years back. I don't know what the problem is really.
Yeah, I'm so sorry to hear about that, Mrs. Kathleen. Be sure that we are here to have the best interest for you and to care for you.
Thank you.
Okay, so we are here to discuss about your health issue. Is that okay for you?
Please, doctor.
Yeah. Can you tell me, you have any idea about what we can talk about today?
Don't tell me that you are gonna start insulin, doctor.
Yeah, I appreciate your concern and your worry, Mrs. Kathleen. May I know why you don't want to start insulin?
Actually, doctor, I have a bit bad experience with insulin. My mother died 2 years back, and she had also diabetes. And I'm just now coming to my mind when I'm giving her this injection, she's feeling a lot of pain and she's crying. And also, doctor, she developed a stroke. And I think the low sugar attack would be related to this. I don't want this insulin, doctor. This is a dangerous drug.
Yeah, I'm so sorry, firstly, about your mom, and my condolences to you and your family, Mrs. Kathleen.
Thank you.
Yeah, but yeah, we are here to clarify the issues for you. Since you
Alright.
have, yeah, since you have diabetes and it's poorly controlled on maximum oral agent or oral hypoglycemic medication.
Yes.
I, I mean the medicine you are taking by your mouth.
Yeah.
So uh, also based on your reading the 3 months glucose, it's so high, Mrs. Catlin. We are worried about the high blood sugar complication. You are aware about that.
No,
Are
tell
you
me what
following
are
me?
the complication?
Yeah. So since the high blood sugar for the last 3 months was high, reaching 13, means that you have a very high blood sugar, and this very high level of blood sugar accumulate in the body, and it might harm most of the organs. I mean the eyes in the form of blurred vision in the
Mhm.
future. I mean, plus the kidney, you might have problem in your kidney,
Mhm.
the frothiness in the water wall, and in the future, I'm afraid to say you might have failure in your kidney, and
Oh,
you might be, yeah, afraid to say that, Mrs. Catlin, you might be on what's called dialysis, and this is a machine connected to you through a blood channel catheter, and the blood will go out to the machine. It's, I mean, an alternative method to the kidney function. Are you following me?
yes, yes, I'm with you. But doctor, I cannot tolerate the pain. This insulin given by injection, and I cannot tolerate this pain. I have a needle
Yeah,
phobia.
yeah. For this problem, I appreciate your worry, Mrs. Catherine. We have the solution for that. Don't worry. We have a very tiny and small needle. Even you can't feel it while pricking your skin.
Mhm.
Uh, y- you might not feel the prick itself because it's a very tiny needle.
Mhm.
It will be like pin a fast break, and
Mhm.
it will do the action immediately. And it might not harm you. You will not see blood and you'll not feel pain. Are you
All
following
right,
me?
all right. I know, and who is going to teach me? Who's going to
Yeah,
teach me how to take this kind of injections?
yes, I appreciate your concern. Your concern is valid.
Mhm.
We have our diabetic nurse. She will sit with you. She will educate you how, and she will teach you how to do prick to yourself
Mhm.
and in an area exposed. I mean, you can see it like the front of your tummy
Mhm.
or the shoulder, the front of the shoulder. But
Mhm.
uh, but be sure and be aware not to inject in the same place frequently. Try to change the sites of the injection
Mhm.
regularly and frequently. This is will be done by a
All right.
pen. It's not a
Mhm.
needle, it's a pen like a pen with a small tiny needle, as I mentioned before. It will be just coming out from the pen and inject. It will be pricked your skin, and the insulin will be inside your body.
So,
Is that
doctor,
okay for you?
yes. And what about the low sugar attack?
Yes. Actually, you will have a bracelet, and we will educate you and teach you about the low sugar symptoms. Since you have any alarming symptoms, you can
Mhm.
feel, and
Mhm.
immediately you can take blood, sorry, candy or sugary diet. It will be always with you in your bucket. The family will be aware about this sugar, about these symptoms also. We can do it as soon as possible whenever you have the symptom.
All
Is that
right.
okay for you? Yeah.
Um,
Regarding your weight, Mrs.
yes.
Kathleen, the insulin has some problem. It can your weight might be increased or you might gain some weight due to the insulin. So
Mhm.
we will refer you to the nutrition team. They will
Mhm.
advise you about some diet regime
Mhm.
you will follow, and
Mhm.
the same diet will be also matching not to have any hypoglycemic attack. Is that okay for you?
Mhm. All right, doctor. All right, doctor.
Okay. Along with that, Mrs. Catlin, I advise you to have regular follow-up to your eye doctor and the kidney doctor, the nerve doctor, and of course the diabetic doctor
Mhm.
to prevent any complication might happen in the future. Are you okay with that?
Hello, no voice.
Yes, yes, we can hear you. Are you okay with that, Mrs. Kathleen?
Hello.
Yes.
Just the voice was interrupted. Yes, continue.
Okay. Are you okay with that? You have to have regular follow-up to the clinics I mentioned to you, diabetic and eye, kidney, and nerve.
All right, but doctor, I don't want this insulin.
May I know why again?
Is there any alternative, doctor?
Uh,
I read
Actually, this is
about
the best.
medication. I read about medication called liraglutide. My cousin told me also it people can get benefits, especially with those with a high body weight. So can I just take it?
Okay, I appreciate your knowledge, Mrs. Kathleen. However, we have to arrange a meeting with the diabetic doctor to
Mhm.
sit
يعمل
with you,
بيض.
and they will explain to
Mhm.
you which is the best interest for your condition.
Mhm.
And I guess that you don't have chance to be on any oral medication anymore.
Mhm.
Uh, so the best medication for you right now is the insulin. So
Mhm.
we will give the meeting appointment to sit to the consultant, and he
Mhm.
will see what's the best interest for you. Is that okay?
All right, doctor.
You have any concern?
Yeah, doctor, I don't want this insulin.
Okay. I appreciate your wish, Mrs. Kathleen.
Mhm.
Firstly, and the last, this is your wish, and you have the right to choose your medication. So I can arrange the meeting with my consultant, as mentioned before, to find
Mhm.
another solution for you. Is that okay?
Yes, okay, doctor. Appreciate it.
You have any other concern?
No, not really, doctor.
Okay, I will hand you some leaflet brochure about insulin and side effect and how to inject and the diabetic nurse information.
All right.
Thank you.
Thank you.
Okay, yeah, you can comment
Mhm.
now. I'm done.
Yes, well done. Excellent introduction, really. Uh, you open the issue of the insulin in a nice way. Um, just a few comments. You can add when she told you, like, what about the low sugar attack, doctor? Excellent. You told her we will teach you about the alarm symptoms. You can also say to her, you need to do a frequent glucose monitoring, or you can open this issue of CGM device, for example. You can say, for example, we will start you on the lowest effective dose that will manage your symptoms, and we will keep monitoring you. Add what you said. And regarding the liraglutide, is there an alternative, doctor? Yes, there is always alternative, but this liraglutide also given by injection. I'm afraid to tell you that it's also given by injection. Besides, for your best interest, as you said, insulin is the best for your best interest, especially in your situation now. You have a high accumulated blood sugar, and you already have these symptoms, and hence insulin will be the best for you. If the patient wants this alternative, it's all right. This is her right, and we can teach her about this alternative. She's refusing till the end. Yes, you can like arrange another meeting with her, or always keep reminding her about this insulin when she comes to her follow-up appointment. And that's it. Uh, this is my comment.
Okay, thank you, Dr. Roda. You're
Welcome.
right, liraglutide, yeah, an injection. I forgot this information. That's why I said to her, you have the whole chance to get oral medication, but it's not oral medication. You're right. So again, it's injection, and she had the phobia from needle, so the same problem. Anyway, it's one of the solution, but still the best interest is the insulin because her hemoglobin A1C is too high. Okay.
I think there
Any
now
com
there is bump.
Yes,
Bump.
there is pump and there is also CGM, continuous glucose monitoring
Yes.
and insulin pump. Yes, you're right, Dr. Aisha, right? Yeah. But
And
again,
also there is
again,
alternative. There is one dose per day, the new form of insulin.
yeah,
No, yes. So we
yes,
can reduce
long
the
acting, yes.
injection by only once per day, primary, then we can increase after that. And I think if she finish, as I also don't want to take, you will ask also, you have other issue with, you can express it. You have any other thoughts in your mind, you need to think again, and offer more discussion.
Actually, you're right, Dr. Aisha. The insulin pump as alternative is a perfect alternative, proper, I mean. Although it's not written in the task, but I'm trying to be strict to the task.
It's
Insulin,
insulin.
yes, yeah, that's why it's insulin again, yes.
Mm.
But I think there is also certain criteria for it. Anyway,
But they didn't give
yes,
you a specific type or specific regular injections.
yes, you're right. Yes,
So
yes.
you can consider this and also consider once daily to be a choose first. Then we can increase this if you tolerate, and or if your sugar controlled on this once injection, we can just make this for you.
I think no enough long-acting insulin. Supposed to be mixed, which is basal uh, insulin. I mean the short-acting
No, in type 2
glucagon one.
you can consider. And there is a lot of patients just take basal insulin in the night and in control. And if they start to control, we can continue till just we can try to for a year with just night insulin.
This is different than the mixed start.
No different. This is triazodic Integridac. This is 24 or 48 now.
Yes, I
Our
know it's long-acting,
lasting.
but this is the basal. But I think before meals they are taking short-acting along
No,
with
not
the
all.
basal.
This is for type
Not all?
1. You should. But for type 2,
Uh-huh.
you can consider
Okay.
just long acting for first line to interfere with insulin. If you will start
Once.
insulin, you should, yes, you can start only this long acting. Then if not control, we can consider mixed start. That 2 doses per day.
Okay. Okay.
دكتور
Okay, thank you,
باسم
Dr. Risha. Yes.
معلش ممكن بس اضيف حاجه regarding when you have to start with the patient. I think we have to explain to the patient the range of hemoglobin A1C should be less than like that
The
first.
number, you mean? Yeah.
ايوه.
Yeah.
The other issue for regarding the body mass index, it is 38. Can I offer her like a option of bariatric surgery, or is not recommended here?
No. It's if not written, I think not advisable. Don't
Okay,
suggest something, yeah, it's not written.
okay.
And we can,
And
for complication, you express, I think, only the kidneys, huh? Or
the what?
for complication of diabetes, you only mention the kidney complication?
The kidney, the retina, the nerves, I mean neuropathy,
Okay.
and yeah, and the diabetic itself as a follow-up.
You can start also by saying, yes, insulin some minimal hazards and bad effect as any medicine, but he will prevent from you some hazard that can affect your life itself and your lifestyle, like ulcers that can cause for you ulcerations they may need some surgical management and joint derangement, or I don't know
Yes.
how to say it by
Yeah,
the language of the patient.
you mean erratic lifestyle?
Yes,
Yeah.
yes. And for the bad effect of insulin, you can say we can manage that these bad effects. It is manageable.
Yes. Okay. I agree. Okay. Thank you, Dr. Aisha. Insulin again as infusion pump, or insulin as injection. Any type of insulin. I think we can open this issue in this scenario as long as they are insulin. Which type of insulin? According to the wish or according to the best interest for him. Since no specific type mentioned in the scenario, so we can explore the three types. But again, if she has the same phobia and she's refusing after all this trial of convince, I think she has the right to refuse, even it will harm herself. But I can arrange a meeting with the consultant to sit with her, and he will try to convince her more, much better than me. Okay. Yes.
معلش يا
Good.
دكتور.
Yes.
سوري. النقطة الثانية بتاعت شيزون جليبتاتين، مش هو برضو risk for putting weight for her. Exenatide is not recommended here also.
I think exercise is neutral, not gaining weight or not putting weight. The insulin and what else? I think glycoside. Yes, insulin glycoside. Both are
Yes.
sulfonylureas. I mean, both
Yes.
are gaining weight, but the other are neutral. The also good for the heart, sitagliptin, and also
أيوة.
good for the heart. The other one for heart failure,
Yes.
gliflozin. Yeah, these
Yes.
are for the heart failure. But the gain issue, the insulin and the sulfonylureas, they are the one increasing the weight.
Yes, regarding the needle for the just we can still convincing us, still trying to convincing the patient that the needle is invisible and you will not see the needle, that is just a small, very thin needles.
Yeah, I
That
said that to her, but still she has hope. I told her the pen contain a small tiny needle, even you might it might break you without feeling it, and this is a
even
real.
you can as the
Yeah.
problem with the needle phobias people that is when see the needle, so that we'll try our best before exaculating the patient to another
Yes,
consultant.
you
Yeah.
can say that. Yes, you can try it before refusing it, and if you still you feel it, you
Yes.
can have the right to refuse. So it's all ways aiming to convince her. Everyone has his own way to convince the patient, and the end result should be convinced. Even if not convinced, and she left the meeting without convinced, maybe this is her task as a surrogate. Maybe
Just
the
check it. It's okay.
examiner, yeah, ask her, don't accept it at all. Refuse, refuse, refuse till the end. And at
Yes.
that time, you will take the mark when you will say, I will arrange a meeting with my consultant to try to convince you. He's better than me to convince you. You
Yes.
might take the full mark when you will say the last option or the last, uh,
Yes.
yeah, this is the last chance to give her as a trial. But this may
Another
be the
issue.
task for the circuit. Yes, yes, go ahead.
Another issue also is diabetes as a non-compliance of people. That is giving me a lot of medications, and I will not take all these medications.
Yes, this is another convincing way I supposed to say, but I forget. You are taking a lot of medication, and it will be only one. You will not take oral medication anymore. It's just one break every day, according
Yes.
to the type. Yeah, this is another way to convince. Yes, you're right.
And also discussing the issue of driving is social about and everything else. That is
Wallahi, you're right. In this scenario, I have to driving, social, who's
yes,
living, the family. The
Yes,
job,
supporting.
all this I forgot. Yes, the job, the
Driving
driving,
or driving on.
hypoglycemic.
Hypoglycemia. Even
He
especially
has no
those taking
hypoglycemia
insulin.
now.
Yes, but I have to warn her. I will warn her. Take care.
Not always the patient will take insulin and have
I know.
hypoglycemia. You will raise the other issue for you. I think this is far
We
away.
are speaking especially about the heavy vehicle driving. The heavy vehicle driving, I think they are prohibited if they are taking insulin not to.
Yeah, this is if the job as a heavy driver, yes, or
Ah,
heavy vehicle.
maybe, but I think
But
this, yes.
Those
How
long
old is
this,
he?
drives, they are driving sometimes for 18 hours, 11 hours, 12 hours.
Yes, for this case, I think she is female. 40.
And now we are discussing
45.
generally. If
Yes,
he is
okay, okay. Maybe it will affect, yes. If it will affect the work, the job, if she in heavy in truck driving, yeah.
Even moving with insulin, because insulin needs the fridge to keep, so it will be an issue for
I
her to
think
take.
storage.
the reset insulin types are not
It
affected
is
by the.
rule. I think there, if the truck driver take insulin, they will not practice the job again. So we can make sure
You
from
mean
this
the
point.
storage, yeah, doctor, right? The storage of insulin should be stored at ref.
Not the problem with the storage. It's problem that it is prohibited for truck driver that they if they on insulin they
Yes,
will
of course. Yeah, this is again
prohibit
for the
from this
driving.
job. Yes.
Mhm.
Mm.
I
So,
think that
Dr. Basil, insulin pen more tolerable to it, even in the car AC, she can she can take it. It's very good. Although the main stem is to convince her to start insulin. But you will, type of insulin or option, I think it is depend which blood sugar is not controlled. Is it fasting or it is postprandial? As we know, long acting or basal insulin act mainly in the fasting blood glucose, short acting for postprandial. Another point I think our colleague Dr. Ahmed mentioned it, although it is not mentioned in the scenario, bariatric surgery. As we know, cut-off point for bariatric surgery is BMI certified, and there is modifiable risk factor. Patient can get benefit. Since the patient BMI is baseline certified, so we are no information for bariatric surgery. Yes, that is it.
okay, thank you, doctor.
معلش يا دكتور بس هضيف إدارة أخيرة.
Yes, sure.
I think the issue for driving should be asked or reviewed when you ask the patient about his vision and also about if you are going to give him if he's aware about glycemic hypoglycemia. In this case, then you have to advise him against driving. If the patient is having vision problem and she or he don't know the symptom of hypoglycemia.
Yes, I think as a safety netting, doctor, you mean. So I will give her warning that if you have in the future any hypoglycemic attack and you are regularly driving, take care. It will be prohibited to drive your car like this. So
Yes,
as a
also,
safety net, yeah, if you have future hypoglycemic attack.
but first to confirm if we know already or she don't know.
Yes, yes, sure. That's why, yeah, we have to have another meeting with her to give her more about the. But this is as a initial meeting with her. It's how to convince her to start. Then, if already she's on insulin and already took the insulin, I have to give her more details about insulin. Then at that time, I will talk about driving, the alcohol, the smoking. You're right. Yeah, even the alcohol here is very important because it might lead to hypoglycemia on the insulin intake. I mean, yes, yes. Go ahead, doctor. Sorry, I interrupted you. You want to add any other point?
شكرا دكتور. No problem.
Okay, most well. Okay, Dr. Roda, your scenario. Also, counseling about medication. You can read Mr. John, 30 years diagnosed as GPA, resistant to steroid and cyclophosphamide. Consultant decide to start biological therapy, rituximab. Sit with Mr. John, talk about the plan, and address his concern. Okay, Dr. Oda?
Yes, okay, 2 minutes.
Yes, sure. Take 2 minutes, then we'll start.
Yeah.
By the way, all ideas discussed in this meeting about insulin and how to convince are valid. So it's not specific or only one way to convince. All are valid. So everyone can convince by his own way. But the end result should be the patient convinced, or if she's resistant, arrange a meeting and that's it. But all ideas were correct about the injection, the alternative, the pump, the driving issue. Also, I think also it's important here, even if as a touch only, not details. You can give her as instruction, please, if you are driving your car for long distances and you start to take insulin, take care. You have to prevent any hypoglycemic attack. You might harm yourself like that. But you don't have to stop her from driving because still she didn't have any hypoglycemic attack. But once she has one of these, that time only she has to stop, plus informing the developer. Okay.
Yes, especially the unawareness hypoglycemia. This is
Still, yeah, this is the awareness. It will be start as awareness first. It will not start by unawareness. Unawareness will be when she has autonomic neuropathy or when she's alcoholic or she's tight control. As we know, the risk factor for unawareness hypoglycemia or hypoglycemia unawareness. So
yes.
this is the only beginning of convincing. We didn't reach yet to the target hemoglobin A1C. When we reach and she's tight control, this is another issue. You have to talk about unawareness hypoglycemia, but still she's 13. I think never ever she will have any of the unawareness hypoglycemia. Okay. I think if we can explore maybe DKA, for example, because the high RBS and missing insulin dose might complicated by DKA, and it's a life-threatening condition.
This is we should mention in the when
Yes,
we're starting explaining
yeah,
insulin the benefit,
exactly.
the
Yes,
side
yeah,
effects.
yeah. So I think this issue or this topic is very large and
Very
never
wide, yeah.
ever will be, yeah, never ever will be finished in one meeting.
Yes.
For 50 or 10 minutes meeting, no, at all.
Yes, yes.
But at least to address and how to convince how to start. But when she starts, we can mention all this complication and warn her about them. Okay, thank you all who shared with us today. Warm discussion. Really, I like this way for discussion. I hope all will discuss like this with me. Don't make it only a written comment. It's a free meeting and it will give you more confidence to talk. Thank you all. Let's start the second scenario. Dr. Oda, are you ready?
Yes, ready.
Okay, here we go.
Yes, hello there. I'm Dr.
Yeah.
Zain, one of the doctor covering the service today. Am I talking to Mr. John, 30-year-old?
Yeah, doctor.
Yeah. It's nice to meet you.
Thank you.
Yeah. We are here to discuss issues related to your health condition. Is that all right?
Sure, doctor.
Yeah. So to be on the same page, tell me how far do you know about your health condition?
Actually, doctor, my disease starting as bleeding from my nose, bleeding in my cough, and some kidney problem, some blood in urine,
Yes.
and I suffer a lot from these things.
Yeah.
Then they diagnosed me as what's called granulomatosis with polyangiitis. I
Mhm.
know it's little horrible disease, but what can I do, doctor? They
Yeah.
give me a trial of some medicine, and they give me some
Mhm.
warning also about the medicine, and I'm taking care of myself, doctor. However, still the
Mhm.
symptoms coming and no any improvement, doctor. I am worried to have kidney failure, doctor.
Mhm. I'm really sorry for what you have been passing through, and I can imagine your suffering, really, Mr. John. So, what do you think that we are gonna talk uh, about today?
Yeah, doctor. Maybe you have some alternative, doctor, for me.
Yeah.
I want to
Um.
be cured, doctor, from this disease at all.
Mhm. Okay. I appreciate your concern, and I guess that you have a good idea about this granulomatous with polyangiitis.
Yeah, doctor. Actually,
Am I
I
right?
they told me, yeah, they told me about, and I read
Yeah.
in the
Hello.
internet about. Yes, you hear
Yeah.
me.
You have a good knowledge about your disease. Am I right?
Yeah, doctor. Actually, I heard a lot about this disease and the
Mhm.
complication,
Mhm.
and also I read in the internet
Mhm.
about this disease. So I have good details about this disease, doctor. But still, I'm worried about
Mhm.
the complication and the kidney failure, doctor. I'm so worried.
Yeah, I appreciate your concern. I can understand your worries. Just I want to add one thing to your knowledge. Can I,
Mhm.
Mr. John?
Sure. Yes.
Um, uh, Actually, this kind of a disease with a problem in the defense mechanism that attacking our body, it has no cure. So no cure for this disease, but it can be controlled. And does that, are you with me?
Yes, doctor. Yeah.
Yeah,
Okay.
and as you say that you have tried a lot of medication, steroids, cyclophosphamide, but still you have symptoms, and you are so worried about your kidney function.
Yeah, doctor. That's why
Yeah,
they
yeah,
told me to have a meeting with you.
yeah. So for your best interest, and decided by our consultant, we are gonna try with you a medication that tried with many patients and showed a good result. Do you want to know what this medication?
Yeah, doctor. Hopefully, yes, please.
Yeah. It's called a rituximab. Do you have any idea about it?
No, doctor, never.
Yeah, do you want me to explain?
Yeah, sure, doctor. If you want me to start on, let me know
Yeah,
more about it.
sure. This kind of medication is called a biological. Don't bother yourself with this term. It means that it's made by something we call it antibody. Also, don't bother yourself with this term. This kind of medication attack our defense mechanism just to decrease it. And hence our defense mechanism will not attack our body, and hence your symptoms that you have will be decreased. Are you getting me?
Yes, doctor.
Yeah. And this kind of medication will be given by through our blood channel. It will not given by mouth. It will be given through our blood channel. Are you with me?
Yes.
Yes. So don't worry. It will be given in the hospital. You will stay in the hospital for a few hours because it's given during a long time. You will be monitored for any kind of a reaction because it is a kind of a new medication. Are you with me?
Yes, doctor.
Yes, and after that, we are going to discharge you, and we will sit together further to tell you about the doses and about the frequency of this medication. Am I
Yes.
clear?
Yes,
And
doctor. Yes.
yes, and this kind of medication, you know, like any medication, it has its benefit and side effect. But if we outweigh the benefit versus the side effect, the benefit will be far more because it's studied on many patients, it controls their symptoms, and it's really a good medication. I want to speak with you just about the side effect. Are you with me?
Yeah, doctor, I can hear you.
Yeah, this kind of medication, as I said, we don't know if you have like any allergy to this kind of medication. So it will be given, as I said, in the hospital, and you will be monitored for that, and we will act accordingly for any kind of a reaction that could happen, like any rash, any itchiness. It can cause for you, for example, like flu symptoms. In some, it might have a problem with sleeping. And in some little people, it may affect their defense mechanism so strongly, so it'll be liable to infection. But don't worry, we are not going to give you this medication and leave you alone. No, we are going to follow, monitor you, and for any side effect that will happen, we will treat it properly. Are you with me?
Yes, doctor.
Yeah. I want also to tell you that this kind of medication, when you go for example, we will tell your GP that you are taking this medication. In case that you are going to take another medication, it will be written in the system that you are taking this medication to prevent any kind of reaction that might happen with another medication. Are you getting me?
Yeah, doctor.
Yeah. So tell me, do you have any concern?
Uh, yeah, doctor. I'm worried, doctor, to have infection, doctor. One of my cousins has what's called TB, doctor. I'm worried about that.
Mm-hmm. I really understand your worries, and I'm really sorry for what happened to your cousin. Hope he's getting well. But this kind of medication, actually, if it has something to be like you to be liable to any kind of infection, this is a very minimum. And in our medical practice, it doesn't relate it to any TB. Does that answer your concern? Might be your cousin has used any other medication. Are you with me?
Yeah, doctor, but I'm worried to have the infection. I mean, if I
Yeah.
have this medicine, my defense system will be weak.
Yeah. This kind of medication, usually in our medical practice, when we give it to patients, it doesn't affect the defense mechanism to the extent that you will be liable to get any kind of like infections. But don't worry, we are not gonna give you this medication and leave you alone. We are gonna keep follow you, monitor you, and if you had like any symptoms, like any increase in your body temperature, any sore throat, any like soreness, any loose motion, don't hesitate and tell us immediately. Does that answer your concern?
Yeah, doctor. Yes. Okay.
Yes. So, do you have any other concern?
No, doctor. It's clear now.
Yes. So, and you are so worried about your kidney. Yeah, so we are gonna always treat you in a group of specialized team, including the defense mechanism doctor, the kidney doctor, lung doctor, social doctor, occupational worker. All of them will work for your benefit. Are you with me?
Yeah, doctor.
Yeah. So may I ask you some question?
Yeah, sure.
Yes. What do you do for a living?
I'm accountant, doctor.
Mhm. And do you smoke?
No.
So thank you, time.
Yes, time is up. Okay. Especially, okay, you can ask, yes, as you did, the alcohol smoking, especially smoking, because the patient has the chest symptoms and also the disease affecting the lung. This is, I mean, from the last. From the beginning, yeah, the introduction was great as usual. The knowledge about the condition and the question, if I want more explanation, and you start to explain if I ask you, but since I have some ideas, so better not to explain because you have a task and the task is full of knowledge, especially, I mean, the biological therapy, and there is a lot to talk about. So when you start to counsel about medication, what are the topic or what are the question you have to ask or you have to mention? The dosage, as you did, the route, injection, and the frequency. Yeah, so the dosage, it will be guided by the clinical pharmacist, calculated, and the frequency according to the also decided consultant. But it's long term or long acting one, takes months or takes months, maybe 6 monthly. And the road to, as you did, is injection and to be monitored while taking this medication. This is regarding the dosage. Then the indication, the indication as you have in your condition, which is GPE and resistance. It might help you in the regressing the symptoms. Then the precaution. You started to explain what to do, and you have to add I think this is the most important missing point, Dr. Roda. We are screening for what before starting any monoclonal or any biological therapy? Isn't? We are screening for viral or virology, right?
All right.
Blood,
All right.
yeah, blood the TB. I explore the TB for you. But it's again, we have to screen for TB because some patient with latent TB might have reactivation if we started this therapy. What about if he has his cousin with TB? So it will be more dangerous, I think. So the answer for the TB, I think, need to be recorrected. That yes, you have to be away from him, to stay away from him. Don't be in close contact with him. Your immune or your defense system will be very weak, and you might catch or you might acquire the infection from him. And in your condition, it might be life-threatening. Plus screening for HIV, hepatitis. This is a very important precaution before starting any monoclonal for any disease. Okay, and some also disease modifying agents in multiple sclerosis, we are doing the same. Okay, this is regarding the precaution. Then the side effects. Yes, you explained some flu-like symptoms. You can also mention the GI upset, as any medication can do. The reaction, skin rash, and you give me also good information about if you have a reaction, we can mention the file to avoid or to not to give this medication again for you. This is the side effect. Then some red flags you can add at home. If you feel fever, as you did, if you feel fever, night sweat, some lumps or bumps, because still the patient might have any infection. He's risky to have infection, plus he is also risky to have a cancer. So you can give him some safety netting and red flags, warning if he has any abnormal feeling, sensation, skin reaction, skin growth, abnormal skin appearance. You might come to us and don't hesitate to call us. This is I think this is the scheme for any medication you can start, whatever the medication. The dosage, the indication,
side effect or the bad
precaution.
effect, the first will be the failure of medication. Also.
Yes,
Like
this is another.
Mm.
Yeah, this is also general effect or unwanted effect for any medication, not only for it. Yes, you can add it to any as a procedure. Yes, you're right, Dr. Ash. So let's repeat it back. The dosage, route, and the frequency, and the route. Then the indication in your condition, as in this disease, for example. Then the precaution before giving you this medication or any medication, you have to run some blood tests. For example, methotrexate, you have to do a liver function test. For for example, also for natalizumab, we have to screen for virology. For the monoclonal or biological therapy, also we have to do like this. For amiodarone, we have to do some thyroid function, and so on, and liver and lung and respiratory function test. So you have to mention some of these precaution or some of these screening before starting any medication. Then precaution already mentioned. Then the other point, the side effect or unwanted effect. As Dr. Aisha mentioned, you can put general rule for all, which is failure of the medication, failure to respond or resistance to the disease to the medication. And the other, like, you can put general symptoms like GI upset for any medication. It happens. Nausea, vomiting, diarrhea. You can put it as GI upset only. No need to mention specifically. The reaction, any medication given eye injection or through blood channel might have reaction. And what else? Yeah, the infection, acquired infection. Particularly the immunosuppressant medication.
Yes, and you will give solution for every side effect you will tell. Or general, I like the sentence that
advice,
the
yes,
doctor
yes.
said that we will not leave you
Yes,
alone, and we will
perfect. Yes, yes.
we will keep follow up and follow up tests, so we can pick any of this bad effect and we can manage it successfully.
Yes, on time. Yes, perfect. So this is also general advice. We will not leave you alone. Our eyes will be on you. We will give you frequent follow-up appointments. So don't worry. Reassurance, then reassurance, then reassurance till the end of the scenario. Even the patient is risky for infection, risky to die. Reassure him because he is in bad mood and he has a disease which is long life with him, no cure. So he will be always thinking about the disease. So at least give him some good words to reassure him, even he will be dying even in the future. But still, you give him some, not false hope, but you give him like support. You are with us and we are with you. We are taking care of you. Even in the palliative, you can do that. Okay.
Yes.
The other last thing, I think the social, yes, as Dr. Roda did, the social support who's living with you, taking care of you. Do you need any support? Do your job? And other social, I mean, smoking, alcohol, especially if smoking, he has to stop any smoking as harming the lungs. Some red flags at the end for the disease itself, if you have time. If you feel like your water work being less, the color is more dark, some urea symptoms, I mean, like feeling dizzy or you are not feeling well, that time also don't hesitate to call us because the medication will be given every 6 months. So in between, he might have relapse, and it's wise to give him some advice about the relapse, and he has to visit us if he has any of these symptoms. Okay, thank you, Dr. Roda, well done. But again, the HIV hepatitis, TB is very important to mention. Maybe this is the most important point in this scenario. And this is not only for monoclonal, for all immunosuppressants. And we are doing that in real life. Yeah, we are checking the physiology or virology before starting any medication. I mean, immunosuppressants, okay? Thank you, Dr. Rada. Thank you, Dr. Aisha, also for commenting. Someone wanted to talk? Yes, Dr. Abdul Hamid?
Yes, so I would want to add some point. Sometimes the scenario will be like this. A patient decided by the consultant to start something like infliximab, but unfortunately, the IGRA test became positive. And then the patient referred to the chest clinic rather than to the specific clinic. And then you need to discuss the issue with the patient, like why postponed it and why you are here in the chest clinic.
The task
Like,
is, again, the task is to talk about the chest clinic.
no, the task, the patient is already diagnosed something like rheumatoid arthritis, and
Okay, yeah,
um,
infliximab. Then,
yes, and then the test we did the pre test before starting the infliximab, and the test became positive for latent tuberculosis.
uh-huh.
And then the patient shifted to the chest clinic to discuss the issue, and they postponed it to start the infliximab due to the
Yeah,
positive latent tuberculosis
yeah,
test.
yeah. I got this. Yes, yes. Yeah. I heard about this scenario.
Yes,
So what's
and then there is a trick in this patient. If the patient is female, you need to discuss also about the if she will get married or if any plan for getting
yes,
pregnant soon. And
yes,
you need to stop the
yeah,
fliximab at least 3 months before starting, before planning any new pregnancy or something like this.
yeah.
We
Okay.
need to discuss this with the patient. This is the trick. Sometimes will be for me.
Hidden.
I
Yeah,
consider discussing the reproductive issue in any female in the reproductive age.
yeah.
This
Let's
will be
put this role. Yeah, Dr.
almost
Abdul
will be a
Hamid.
hidden issue in any female in reproductive age. There will be a hidden issue to discuss this issue with her.
Yes, I agree with this with you on this point. So let
Yeah.
us put a rule. Whenever one of us will see a patient, female, in the childbearing period,
Yeah.
20 or 18 till 40.
Till
This age
45.
in, yeah, even 45. Okay, but yeah, me 45 still old. Anyway, okay, 45. But the most concerning age, which is 30, 30s, like this. Okay, what we will do, yeah, when we see the age, make a circle
Put in your mind. Yeah.
and yeah, put pregnancy for
Yes.
any counseling, whatever the kind of the disease.
Yes. Whatever
If
thyroid, whatever
yes,
start new medication,
exactly.
whatever.
Let's put this role in our mind.
Yes. Yes.
Maybe this point will give you the full mark, or at
Yes.
least will give you the pass if you fail to convince or if you fail to explain the other points. But
Yes.
once you do this, you will get the welfare, and
Welfare.
it might be the hidden agenda. Yeah, it might be also the hidden agenda in this scenario, the
Yes.
pregnancy. If you didn't mention the pregnancy, it will harm you. So
Yes.
anyway, let's put this role in our mind whenever we see this age, make a circle and talk about pregnancy. Not only pregnancy, the
Just ask.
OCP.
Just
Yeah,
ask any future plan of pregnancy.
yeah.
Yeah.
And the
Just
OCP, by the way, also, for example, for the antiphospholipid syndrome, yes, SLE. So give an instruction about OCP, or at least include the woman doctor to be following you with us in the team.
yes. Yes.
Okay? Yeah, the good advice. Thank you, Dr. Abdul Hamid. Any other concern related to this scenario? Dr. Aisha,
Mm,
you want to add? Dr. Abdul Hamid, you want to add?
for the latent tuberculosis, is not infectious. If the patient asks or if the patient asks about the infection or not infectious, it is not contagious anyhow.
Yes, it's not.
Yeah, because it is
If
airdrop.
if he is the one, yeah, if he is the one having
Yeah,
latent TB, he shouldn't start the medication.
yeah, no need for
But if
isolation, no need for
no
stopping the
need,
job, no need for anything.
no,
Yeah.
no.
Yes.
Okay, monoclonal biological therapy, one of the most, I think, nightmare, because maybe most of us doesn't or don't know more about the medication.
Yeah,
For example,
this OMAB tribes they are emerging many new medicines every time.
yes, that's what we don't know more about them.
Yes.
Either the side effect, the indication, the dosage. So what we will do, try to take a breath and be diplomatic in the answer. And if you have, yeah, to talk as general, yeah, any monoclonal or biological, you can warn the patient about the infection,
Yes, yes.
about the cancers.
It is immunosuppressive
Yeah,
anyhow.
yeah, about the cancer, about reactivation of TB, for
About the skin
example.
changes,
Don't
about yes, don't
about
expose
yes,
sun exposure. No.
exactly. Don't expose long to the sun. Even don't contact sick patient for long time. This
Yes.
is also, yeah, like a golden advice. However, it's simple. Why? Because you might have infection from him, and that's it. It will be harming you. And if he asks you a specific concern, which is very weird for you, try to escape by a clever way. Say, tell him, yeah, up to my best knowledge, what I know, let me arrange a meeting. Let me ask my consultant or my senior, and I will be back to you to give you the proper answer. This is general advice. Communication is like how to escape if you don't know how to answer, but answer by diplomatic one. This is the communication skills. Okay. Thank you, Dr. Abdulhamid, for sharing with me. Dr. Ahmed ask if patient come positive for TB screening, need to complete management for latent TB, then start. Yes,
Yes.
yeah. After he starts some medicine, which is rifaximin, I think for 6 months, or a combination for 4 months.
For 4 months. Yes, yeah.
Yeah,
We will make it
isoniazid
optional.
and
We will
rifampicin.
start medication from 2 to 3 months, from 3 to 6 months, or something like this.
Yeah. So 6 months for rifampicin single, I mean, agent,
Yeah.
or
Refiner.
combined for, yeah, 3 to 4 months. You can postpone the medication, or you can postpone the biological till finishing this treatment. This is the answer regarding the scenario given earlier. Someone said about latent TB. So treat the TB first, the latent TB, I mean, before starting the biological.
Yes, you cannot start because this will make reactivation of the latent of the
Mm-hmm.
drugs. It makes
Mm-hmm. Yes.
reactivation.
Yes, you're right. Or at least at the end of the, if you are urgent to start, at the end of the medication for latent TB, for example, at the last month, but also after multidisciplinary opinion, the pulmonologist with the rheumatologist, infectious disease, clinical pharmacist, and don't forget to mention the clinical pharmacist for any chemotherapy medication. By the way, Dr. Roda, you forgot the consent. Monoclonal, as any immunosuppressant, need consent. So at least verbal consent. What's your opinion about our medication? Are you agree to start it? If he said, I will think about, it's okay. If he said, yes, I'm agree, then give him the consent, tell him about the instruction for the consent. Read the consent carefully and sign at the bottom when you finish and agree for the medication. Yes, consent is very important. Okay. And any comment? Which, yeah, hepatitis B important to be checked. Yes, we mentioned this. Okay. I think we checked, we discussed all the point. Dr. Roda, again, the last advice I wrote also, I didn't mention. If you want to say, as I as I said to you, you can better say as mentioned before. I think, yeah, makes sense that you are saying it was mentioned before. But if you are saying, as I said to you before, means that she's not listening to you, or she's not understanding you, or she's like she cannot understand. So don't assume that you said it and she's the one that didn't get it. So you can say as mentioned or as discussed earlier. Okay. This is general also advice for the communication skills. Okay. Let's end the session. If no question, no concern.
Dr. Basil,
Yes.
if I need to say to the patient, clinical pharmacist, how to say it in a non-jargon way.
What is it? The what?
If I want to say to the patient, clinical pharmacist, how
Clinical
to say it
pharmacist?
in a non-jargon way.
Yes, clinical pharmacist which is the doctor in the pharmacy who prescribe and who detect and calculate the dose for the medication. You can say, by the way, you can mention any jargon, but explain it in the simple way. So if you want to say, okay, say it. The clinical pharmacist will be with us in the team. If you want, then you can explain, yeah, he is the doctor in the pharmacy, calculating the dose, and he is sitting with us in the meeting, and he is observing the reaction for the medication. Along with infectious disease, he is the doctor of infectious disease concerned for the antibiotics in the hospital and the infection in the hospital, and so on. You got it.
Okay.
Okay, thank you, Dr. Khalid. Any other question someone wanted to ask? Okay, no question. We'll end the session. Have a nice weekend. See you on Sunday. Good luck and good night. Assalamu alaikum wa rahmatullahi wa barakatuh.
عليكم السلام.